Good morning, guys. This is the reason I'm wearing a suit and everything is I just gave my residency interview. But we're going to go through advanced Step2CK cardiology. Also, I'm going to include in all of this at the end. I'm going to include the management of all like the bad rhythms. Usually, we're good at recognizing EKGs, but we're not really sure about what to do. And there's not one place where like what do you do with all the different rhythms? Is there? And so we're going to do that in the end. So I'm just going to go through everything very quickly. The first thing is evaluation of chest pain. The reason I put this up here is you guys probably know all of this. Just know if they're able to exercise, and they have a normal EKG. So if they have like a standing left bundle branch block, if they have a standing abnormal EKG, you cannot exercise stress test them, because if the EKG is abnormal and you exercise EKG stress them, you're comparing an abnormal with EKG with an already more abnormal EKG. So in that case, if they do not have a normal EKG, you're going to exercise stress imaging them. So you're going to exercise echo them. So like first check if they can exercise. If they can exercise, do they have a normal EKG? If they have a normal EKG, then you can exercise EKG them. If they can exercise but they have an abnormal EKG, you're going to exercise imaging stress test them. So there's just like kind of like a difference there that you guys have to be aware of. The next thing is which medications to hold. You can pause this slide and just take a read at these. This is just something that people kind of forget. This is not something commonly tested, but this is something that kind of you should know. And the next thing again is just this is the same thing. If you're doing exercise stress EKG, you cannot do it in left bundle branch, you cannot do it in pacemaker, and you cannot do it if they cannot reach target heart rate. And that target heart rate is this. And kind of how the way they test this is they give you really bad COPD or really bad like osteoarthritis or like a knee replacement or something. They can't walk. If they can't walk or can't run, they can't exercise EKG them. Then this is just know these other two ones and know kind of the contraindication. This is a reactive airway diseases here as well, so you can just pause the slide and kind of take a read at this, but like just know these. I see people get these wrong all the time. Then okay, another thing is a word on, let me move me up here, a word on MIs. Obviously remember the all of the drugs that you're going to give in acute coronary syndrome when you suspect MI, this like morphine, oxygen nitrate, sublingual IV or paste, aspirin 325, beta blockers, ACE inhibitors, statins, heparin, which is anticoagulation, clopidogrel, and beta blockers if it's not acute. Now, the thing is, you're going to know all of these. I want you just to know a little bit more. So know the contraindications of specific things. So now morphine. Morphine, we give it to stop the sympathetic activation and the pain that comes with the cardiac arrest. So do not give morphine as it reduces preload. So do not give morphine in a right-sided MI. Do not give nitrates in a right-sided MI because these are preload dependent. Like you guys already probably know the mechanism. And the last thing is obviously do not give diuretics in a right-sided MI. Then the next thing is avoid beta blockers in hypotension, bradycardia, heart failure, reactive airway disease. Avoid that's about it. That's about it. Just kind of know a little bit more, know what drugs to give, and know when to not give certain drugs. So you'll be good. I just wanted to make the point here. And right-sided MI is like know how to diagnose right-sided MIs and everything. Okay, here's another thing that I see a lot of people get wrong. What people get wrong is you can PCI someone. What are the guidelines for PCIing someone with acute STEMI? First of all, it is within 90 minutes if you reach a PCI capable facility. It is 120 minutes if you reach a PCI non-capable facility. We give you 30 extra minutes as buffer zone to reach a facility. And it's within 12 hours of symptom onset. So it could be that you started having like the acute coronary syndrome pain 9 hours ago, and it's been 15 minutes of you that you've like come to the emergency department. We're still going to PCI you. It's not within 90 minutes of symptom onset. It's within 90 minutes of arrival at the facility. So even if they had the symptom onset 9 hours ago, you're still going to PCI them. This is something people like get wrong all the time. So it is within 12 hours of symptom onset. This part is the part that people get wrong a lot. So PCI is obviously better than thrombolytics, and thrombolytic time is door to needle time is usually less than 30 minutes. You can pause it and read everything else on the slide, but that fact that within 12 hours of symptom onset, you're good. You can still get PCI'd is something that kind of people forget. Okay, then the next thing is post-MI complications. As you kind of see, I kind of went into like before MI, acute coronary syndrome, MI, and now post-MI complications. Obviously, in the first 24 hours, ventricular fibrillation is going to kill you. This is why we give beta blockers. Beta blockers kind of stops the VFib. Then the second thing is in 1 to 3 days, a very common adverse effect is acute peri-infarct pericarditis. Now, how we generally treat pericarditis is NSAIDs and colchicine. This is one of those unique instances where we do not give NSAIDs. Why we don't give NSAIDs? Because there's a risk of free wall rupture and a hemorrhagic pericardial effusion. So this is kind of like one of the few instances where you have a pericarditis, but you're not treating with NSAIDs. And then 3 to 5 days posterior papillary rupture and intervertical septal eruptions. Know how to differentiate these. There's a question in UR where you kind of have to differentiate these. So just do that question and you'll get it. But just the reason I put the slide up here is about that this 1 to 3 acute peri-infarction pericarditis is not treated with NSAIDs. We treat this literally like supportively. So this is the next thing. This is now post-cardiac injury, the Dressler syndrome, which happens in that 1 to 2 weeks after like the MI, and this is the cardiac antigens presenting and yada, yada, yada. Again, NSAIDs, aspirin, and colchicine, and then steroids when refractory or when NSAIDs are contraindicated. NSAIDs are contraindicated in like, I've forgotten what they're called, like CKD and stuff. So, and avoid anticoagulation, again, because there's a risk of hemorrhagic pericardial effusion, but it's chill. You can give NSAIDs here. Okay, moving on. Stent thrombosis and stent restenosis. So if you put a PCI in within 12 hours of symptom onset, within 90 hours of coming to a facility, or within 120 hours of coming to a facility that's non-capable of PCI, you're going to put in a stent. When you put in a stent, two things can happen. Thrombosis can happen and restenosis can happen. Thrombosis happens fast, right? Like you put in the stent, you put him into like the ward, and he thromboses that stent. This is a fatal complication, and this happens really quick. And restenosis is slowly plaque builds over that stent again. So the reason to prevent both of these, we give dual antiplatelet therapy. So we give aspirin and a P2Y12 inhibitor, which is clopidogrel, right? Usually or ticagrelor, and we give it for 12 months. So after a stent, they should be on this for 12 months. And the most common predisposing factor for stent thrombosis or restenosis is premature discontinuation. The patient goes to the pharmacy. The pharmacy fills clopidogrel, doesn't give him aspirin, fills aspirin, doesn't give him the other one, and the patient just takes that and his stent thrombosis. How these are going to present is with another MI. Like they're going to have an MI on top of like history of previous MI. So you're going to think if it's very sudden, it's thrombosis, and if it's a late, it's restenosis. And then just another thing I wanted to point out, this is something that's pointed out in first aid for step 1. It happens actually in real life as well, is ticagrelor, this P2Y12 inhibitor, these cause this thing called neurogenic dyspnea, where there's no cause of the dyspnea, but it's kind of just like the medication itself. Comes in the name Brilinta in USA, and just neurogenic dyspnea. This is written in first aid as well. If you go to hematology and if you go to the drugs in the end, this is kind of written there. So it's just something you kind of want to keep in the back of your mind, because like you'll be thinking, is this another MI? Is this like heart failure? Is this COPD? And it's actually the medication. So kind of know that this causes neurogenic dyspnea. Another word about heart failure, a lot of people like know heart failure, preserved ejection fraction, and reduced ejection fraction. Reduced ejection fraction, what's reduced ejection fraction? Normal ejection fraction is about 50 to like 55%, or like kind of above 60. Actually, I've forgotten, but whatever. Heart failure with reduced ejection fraction is less than 40. Heart failure with preserved ejection fraction is less than 50. Anything in the middle is borderline. Just know like the terminology. Obviously, we know that there's a lot of drugs for reduced ejection fraction. We don't have that many drugs for preserved ejection fraction. I just wanted to point out that these are all the causes of preserved ejection fraction. This is very common if you kind of look at all these causes. But you know, we can actually treat this. And we treat this with dobutamine, with the Emperor trial, with empagliflozin. This is a really good trial in the New England Journal of Medicine if you kind of want to take a read at it. And loops and loop diuretics and oxygen. So we kind of do use drugs for this. Empagliflozin increases decreases mortality. So we use empagliflozin from the Emperor trial. We use dobutamine, loops, and oxygen. So like previously used to be taught that there are no drugs that treat this condition, but now we do have some drugs. Okay, then what if the patient comes in with like a congestive heart failure exacerbation? This is probably reduced ejection fraction or whatever. You're going to order all these tests. You're going to give LMNOP. I really love this mnemonic. Lasix, morphine, nitrates, oxygen. Okay, question here. Do you give Lasix when, what if he has CKD? If someone has a heart failure exacerbation and clearly they're in a volume overload state, do you give Lasix and will Lasix improve his condition? Because Lasix is like, it's furosemide, it's a diuretic. The answer is yes. Even though his kidneys don't work, even though you will not increase his GFR or whatever, Lasix will work by increasing the pulmonary lymphatic flow. And this is kind of weird. There's a really interesting trial on this about why Lasix working in like patients with CKD, with CHF. Lasix still works. So still give Lasix, even though like the kidneys are like shot. And then morphine, nitrates, oxygen, positioning. And obviously avoid beta blockers and have a low threshold to intubate, and in the start give non-invasive positive pressure ventilation. But this is just, I wanted to point it out, like that funny thing about Lasix and what you do in a CHF exacerbation. Okay, so obviously pull up all the hyperkalemia EKG changes. You're gonna like say all that thing which is like progressive, like PR lengthening and ST segment elevation and peak T waves and whatever, right? Just know all the hyperkalemia EKG changes and know that digoxin causes hyperkalemia and it causes other abnormalities on the EKG as well as like the hyperkalemia EKG changes. And these are the abnormality that it causes. It causes increased venous tone, atrial tachycardia, and sinus bradycardia. And precipitants of digoxin toxicity are hypokalemia. This is kind of that fun fact. You kind of need to know the physiology of this if you're on step 1 level. Renal failure, rapamycin, diltiazem, amiodarone, and diuretics. So these kind of drugs are commonly given with digoxin. So have a very like low threshold of suspicion, like high threshold of suspicion, like suspect digoxin toxicity when anyone's ever on digoxin in any question, and check if they're taking all these other drugs, and check if they have hypokalemia or renal failure. But the thing is about the hyperkalemia and digoxin toxicity, right, does not show the hyperkalemia EKG changes. It shows no peak T waves. Instead, you will have flattened T waves, a prolonged PR. Do you get it? Like so know the hyperkalemia changes on EKG and know the digoxin hyperkalemia is different. And have a very low threshold of like suspicion for digoxin toxicity, and know that you are going to have to like mess with the dose of digoxin if you're messing with the dose of any other medication. So that's the reason I put this slide up here. The next one is, again, common surgical indications for infective endocarditis. Know when you have to take this patient to surgery. They're very easy ones are in here. UpToDate has like a good list. You really don't need to know that at step 2 level, but you're going to take them to surgery at some point. Then just another thing I wanted to point out is like we've memorized that, strep bovis, if this guy has strep bovis, endocarditis, get a colonoscopy because like, he probably has colon cancer or something, right? Well, that's great and everything, but the second thing you kind of want to get is an LFT and hepatitis screen, because this strep bovis also lies within the hepatic sinusoids, and if it can kind of come inside the body from there. So get a colonoscopy, get LFTs and hepatitis screen as well. That way, like now you know 2 things about strep bovis. And then just remember that if you ever can't give vancomycin to cover like Staph aureus or whatever, give daptomycin. The next thing, this is now the part of the EKGs. I'm just going to finish all the EKGs you need to know and what you need to do about them. This is AFib. Just another thing about AFib is just keep this nugget of fact in your mind that if you need to pharmacological stress test these AFib patients, right, sometimes like they won't be able to run, they're going to be old, and they're going to have AFib, and you're going to want to stress test them. So you can't and they have like an extra knee or some shit. Like they have like osteoarthritis or something, and you cannot like exercise stress test them. You're going to pharmacological stress test these patients. You're not going to pharmacological stress test them with adenosine, because adenosine is going to mess them up and it's going to cause like COPD type things and they're going to die. You're going to pharmacological stress test AFib patients with class 1C antiarrhythmics, right? Because adenosine can provoke AFib with RVR, and AFib with RVR kills people. But whatever, like just even if you don't know this part, this is a little complicated. I kind of don't have my own head wrapped around this, but just this is the reason I put up AFib. So the thing about AFib is, AFib, if they're hemodynamically stable, you can rate control or rhythm control. Both are equal. What is rate control? Rate control is just fancy for calcium. Let me get my pen. Rate control is fancy for either calcium channel blockers or beta blockers. Those are first lines. If those drugs are contraindicated, when would a calcium channel blocker be contraindicated? Ask this from yourself. When would a beta blocker be contraindicated? Ask this from yourself. If either of these drugs are contraindicated, you're going to use DIG or amiodarone. And no, we previously went over DIG issues. And then after you rate control them, you're going to determine their CHA2DS2-VASc. If their CHA2DS2-VASc is high, like for man or woman, you're going to anticoagulate them with whatever. So AFib and hemodynamically stable, decide to rate control with beta blocker or calcium channel blocker. If doesn't, digoxin or amiodarone, do CHA2DS2-VASc and decide to anticoagulate. That's all you need to know. If you decide hemodynamically stable and they're not a candidate for rate control, you're going to rhythm control them. For rhythm control, you're going to cardiovert them. You're going to pharmacological cardiovert these guys. If it's in less than 48 hours, we call that new onset AFib. Just go ahead and cardiovert them, electrical or pharmacological. Electrical is like synchronized cardioversion. Pharmacological is with any one of these drugs. So cardiovert them, they're good. They're going to come back in normal sinus rhythm. They can go home. If they're greater than 48 hours, or it's been a long time, he's like, I went to sleep, I woke up in AFib, you don't know. Now you need to get a TEE. You're going to get a TEE. If there is no clot, cardiovert them and send CHA2DS2-VASc them and determine their anticoagulation risk. If there is a clot, anticoagulate them for 3 weeks, do another TEE. If there is no clot now you can. I explain this horribly. Just read this, guys. Pause the slide and just read this. This is kind of what you need to know. This is everything you need to know about AFib and how to manage it, at least on step 2 level. I'm just going to move forward. Back forward. Okay, what about if AFib is hemodynamically unstable? So AFib with RVR, AFib with like the guy has no pulse, AFib the guy can't breathe. You're going to synchronize electrical cardiovert them. right? So you're gonna synchronize. Majority of the cases, you're gonna synchronize electrical cardiovert, and you're going to defib them if like shit gets really bad. But you're going to synchronize electrical cardiovert them. So hemodynamically stable, you have the option, know what to do in those cases, and then hemodynamically unstable, you're just going to synchronize electrical cardiovert them. This is what happened? Okay, so this is an SVT. SVT, you can pause this and read this. This is straight up from UR. I just want to point out that SVT is a dumpster classification. How much time do I have? Okay, and SVT is a dumpster classification. It has all of these rhythms are within SVTs. So we just did AFib. A-flutter is treated exactly the same as AFib, so keep these two similar in your mind. Multifocal atrial tachycardia, paroxysmal atrial tachycardia, AVRT, and AVNRT, right? So this is a dumpster classification. I'm just going to teach you what to do for specific SVTs. So for PSVTs, which is AVNRT, which is previously called PSVTs, I'm going to show you what to do. You're going to recognize that it's a PSVT. You're going to recognize that it's any SVT actually. And the first steps you're going to do, if they ask you what's the first step for you to do, you're going to do vagal maneuvers. Vagal maneuvers is you're going to do Valsalva, or you're going to do carotid sinus massage. Some SVTs will terminate. AVNRT will basically terminate, and anything else will delineate your rhythm. So if you see an SVT, first step is vagal maneuver. If you vagal maneuver and the SVT does not abolish or delineates rhythm, you're going to give IV adenosine. IV adenosine is going to slow down the heart, or IV beta blocker or calcium channel blocker. This is if they're hemodynamically stable. If they're hemodynamically unstable, and this is just examples of what unstable means, you're going to synchronize cardioversion them. You're going to basically cardiovert them. So if you ever seen SVT, vagal maneuvers, adenosine, beta blockers, calcium channel blockers, if stable. If unstable, cardiovert. This is multifocal atrial tachycardia. Pause the slide and take a read at this and know when this happens. This is very unique. They generally don't ask questions about this, but just know what to do. Yeah, you're a minute. So this is Wolff-Parkinson's White. Wolff-Parkinson's White, you will recognize it. You will recognize the delta wave in the prolonged PR interval. This is the only indication in medicine where you use procainamide. If they don't put procainamide in the options, know that you can also use ibutylide. And then if unstable, again, synchronized cardioversion. Remember, I told you that we're going to synchronize cardioversion more often than we're going to unsynchronize cardioversion. So it's just Wolff-Parkinson White. Just remember what we do for this. For Mobitz type 1, Mobitz type 2. For Mobitz type 1, generally, if they're hemodynamically stable, we generally either don't do anything or we transcutaneous pace. If they're hemodynamically unstable, we give atropine because we speed up the heart, and then we cardiac pace them. But this is Mobitz type 2 here. Generally, for Mobitz type 2, we pace them. Mobitz type 1, we kind of leave alone. But now you know. Wait, pen and clear. Okay, sinus Brady. Sinus Brady is simple. This is all the things that happen in sinus Brady. Sinus Brady, you're going to speed up the heart. You're going to give atropine. You're going to give atropine 6 times. If that doesn't work, you're either going to transcutaneous pace them, dopamine them, or epinephrine them. Right? This is all you kind of need to know for step 2 level. Approach to wide complex tachycardia. I'm just going to go forward 1 second, and then I'm going to come back to see this. So you see something that's wide complex. So if it's a wide complex tachycardia on the USMLD exams, right, it's going to be one of 4 things. It's going to be monomorphic V tach, polymorphic V tach, torsades, or what was the last one? VFib. Okay, so we're going to start with V tach. V tach is ventricles are going very fast, and ventricles are all beating very similar. Do you see how all of these, like everything is similar, man? So this is monomorphic V tach. And this thing it's showing to you, which is kind of a little different, this is just a fusion beat or something. So monomorphic V tach, here's what you're going to do. You see this rhythm, you're going to ask, is there hemodynamically stable or unstable? If they're stable, they're going to get amiodarone and procainamide, right? Amio and procainamide. If they're unstable, you're going to synchronize cardiovert them. Remember, I told you we're going to synchronize cardiovert, much more common than unsynchronized cardiovert. So monomorphic V tach, if they're stable, basically you do pharmacological cardioversion. If they're unstable, you do electrical cardioversion. So kind of remember that. So stable, this, unstable, that. Polymorphic V tach, same thing, ventricular tachycardia, but look at this, man. One is going like that, and the other is something like that, the other is something like that. Same thing. If they're stable, pharmacological cardioversion, amio and procainamide. If they're unstable, defib. You're just going to defib them. This is one of the unique instances where we say V tach. If polymorphic V tach, generally on they're going to say V tach defib, VFib defib, but no. You know monomorphic V tach. What was it? Synchronized cardioversion. Polymorphic V tach and unstable non-synchronized cardioversion, defibrillation. So this is kind of something that you need to know. And then the last one is VFib. VFib is a wide complex thing. Look at this. There's a bizarre looking rhythm. Obviously, defib this. So defib, VFib, and defib polymorphic unstable VTach. Now I'm just going to go back to the slide I had previously, which is like, what the hell? You guys will probably be like, what the hell was he talking about? Wait, how do I go back? This slide. So the thing is, if you have a wide complex QRX, right, you need to decide, is this VTach, VFib, or anything else? The thing is, right, it can probably be VTach. It will probably be VTach because VFib is like the person's dying, right? It'll probably be VTach, but sometimes it's not VTach. Sometimes it's this thing called SVT with aberrancy. You don't really need to know how to figure out how to differentiate VTach from SVT with aberrancy. Do you see, like, if you kind of follow out these arrows, you're kind of end up in all of these things. And like, because the thing is, if you decide that it's an SVT with aberrancy, you don't need to like pharmacological cardiovert or like defib or whatever them. You can just kind of do what we do for SVTs, which is what we discussed earlier. You don't really need to know this at this level, but remember what we do for SVTs, remember what we do for monomorphic VTach, polymorphic VTach, and for VFib, and then for torsades, everyone knows to give magnesium. I think that's everything I have for you guys. Oh, okay. This is just the last thing. Just as like, so far we've defibbed only two things. We've defibbed unstable polymorphic VTach and we've defibbed VFib. So this is VFib pulseless VTach, and they say defib this. And remember, if it was monomorphic, and unstable, we synchronized cardiovert them. But I will also like let you know that yeah, we synchronized cardiovert them. If they don't come back, we defib them. So in many cases, if you see VTach, or if they're just generally like they give you VTach, you're going to defib that. But if they give you monomorphic VTach and there's an option, choose synchronized cardioversion. If there is no option, choose defib. If they're polymorphic VTach, defib that always. So only two instances where you technically, for step 2CK purposes, defib is VFib or polymorphic unstable VTach. Everything else you do something different. And then PEA or asystole, you know, when they flatline or whatever, right? You know how like they shock them in the movies? You're not supposed to shock them. You're going to CPR, airway, epinephrine, and you're going to pulse and rhythm check, yada, yada. So the only shockable rhythms are the synchronized cardioversion rhythms, and the only defibrillation rhythms are these rhythms here. Everything else, you don't shock. That's everything I have for you guys. Yeah, that's everything. And I will see you guys in the next one.